Hello and welcome to another episode of Why Does My Ventilator Hate Me and Why Do I Resent My Ventilator? I'm your host, Jason Jensen, and we're going to discuss a little bit about mechanical ventilation and mechanical ventilation with regards to the Caravent ATV. So let's get into it here. So we're going to talk a little bit about basic terminology for mechanical ventilation, very basic stuff that some of us might know, some of us might not. We want to understand how to set up the Caravent for pre-hospital patients, also set up the Caravent for long-term ventilator patients, usually when it comes to interfacility transfers. And then we're going to talk a little bit about troubleshooting the Caravent ATV. So respiratory rate. We should all be really familiar with respiratory rate by now. If we're not, go ahead and hit pause. Go back to your EMT or paramedic textbook, do a little bit of reading, come back and finish when you understand what respiratory rate is. But when we talk about manual or mechanical ventilation of a patient, we can't just put everybody at their normal respiratory rate. So here I've listed the adult, child, infant respiratory rates that are normal ranges. But we really have to consider more when we're talking about managing airway and managing people's respiratory rates. So we need to understand what their respiratory and their metabolic needs are before we just go ahead and put them on a rate. So for example, a DKA patient. So we have a patient who's in diabetic ketoacidosis. That patient is generally going to be breathing super fast. Their body's going to be increasing their respiratory rate in an effort to save their life. And the reason for that is because carbon dioxide and pH work conversely of each other. So when someone's in DKA, their pH is going to be going down, making them more acidotic. And what they're going to try to do is they're going to try to blow off that carbon dioxide to raise their pH. So they work inversely of each other. So when pH goes down, CO2 usually goes up. When CO2 goes down, pH goes up, making the patient more alkalotic. So that's what they're trying to do. So if we come along, we paralyze, intubate them, and put them on a respiratory rate of 16, all you're doing is giving them a kick in the butt, pushing them towards death's door, and that's not what we're here trying to do. So when we put someone on a respiratory rate, you need to consider respiratory and metabolic needs of the patient, and that goes for BVM as well. You can't just bag someone at a normal respiratory rate when they need a higher respiratory rate. Tidal volume, the amount of air that we're going to move with each breath. Usually you see it on ventilators as VT or some variation of. Just so you know, the Caravent ATV does not have a tidal volume knob. Please do not set your minute volume knob thinking that you're setting tidal volume. You need to understand how to calculate tidal volume, and before we calculate the tidal volume, we need to know how to calculate their ideal body weight. So the standard formula is going to be for adult males, 50 plus 2.3 times their height in inches minus 60. Females, 45.5 plus 2.3 times their height in inches minus 60. So let's take me for example. I'm 5'9", makes me 69 inches. We're going to minus 60 from that, remembering our order of operations from 6th or 7th grade math. So that gives me a value of 9. 69 minus 60, 9. We're going to multiply that by 2.3. That's going to give us 20.7. And then we're going to add that to 50 to get 70.7. That's my ideal body weight. 70 kilos, make it easy. Then we're going to multiply that by either 6 to 8 mils per kilogram, and that's going to give me my tidal volume. For the ventilator purposes, we're going to calculate it at 8. There's a bunch of different tidal volume and strategies out there with the ventilators. However, we're going to make it simplest as possible. We're going to go with 8, and we're going to work from there based on our patient's needs. So let's just say you're thinking to yourself, there's no way that I'm going to remember this formula. I need an easier way. Well, what we're going to do is we're going to shoot from the hip. So what do I mean by that? So what I do is I use myself as an example. I know what my ideal body weight is. Um, I'm going to look at someone and let's say they're 5'5", 150 kilos. So we know that that person's not anywhere close to their ideal body weight. But what I do is if I'm 5'9", I'm 4 inches taller than they are, and I'm going to figure that their ideal body weight's somewhere around 60, 65, right? So you need to understand that just because someone's obese and has a lot of tissue mass does not mean that their lungs are proportionally larger. So you need to use lower tidal volumes, otherwise you can cause barotrauma. So keep that in mind. Minute volume, the amount of air that we move over the course of a minute. Minute volume is about 100 mils per kilogram of ideal body weight for most people. But with mechanically ventilated patients, we often need a little bit more to overcome the dead space in the vent circuit. So we're going to use about 120 mils per kilogram of ideal body weight. So I've got a little example down here. If we take an 80 kilogram patient, multiply that by 100, they move about 8 liters or 8,000 mils of air over the course of a minute. Their tidal volume is going to be about 640. And if we divide our minute volume by our tidal volume, that gives us about a respiratory rate that we should be in, assuming that they don't need a higher or a lower respiratory rate based on their respiratory and metabolic needs. So with the ventilator patient, we're going to use 120, right? So 80 times 120 gives us 9.6 liters or 9,600 mils. Divide that by 640, and we're going to put them on a respiratory rate somewhere around 15. And the great thing is we can take our respiratory rate times our tidal volume to get our minute volume. So we can work backwards. So now we've moved from basic order of operations math. Now we're doing a little bit of algebra. So move back and forth. Respiratory rate times tidal volume equals minute volume. Minute volume divided by tidal volume equals respiratory rate. Fractured of inspired oxygen. So FiO2. What is the concentration of oxygen that we're giving them? 0 to 100%, right? So we're going to start off with enough oxygen based on their needs. Our ventilators only have two options. By far the most limiting factor of our ventilator, we have an option of 60 or 100% FiO2. Just so you know, 100% is not always what we want to give these patients. Our COPD patients do not necessarily need 100%. So with such limited amounts of what we can vary the FiO2 at, we're going to choose the lowest, safest option for the patient to keep them oxygenated. Just so you know, though, ventilators, when we go into transfers, ICUs, skilled nursing facilities, ventilator care adult homes, they're going to be in probably generally much lower FiO2s. We don't have an option to decrease the amount of oxygen we're giving them, so we're going to give the lowest possible oxygen based on their needs. So PEEP, partial end expiratory pressure. So what PEEP does is it helps keep our alveoli open to allow greater gas exchange that overcomes shunt, VQ mismatch, massive pulmonary embolism, whatever the case may be. Something is causing gas exchange to decrease, causing oxygen saturations to decrease. So what we're going to do is we're going to add PEEP to help stent open alveoli. Our intrinsic PEEP is somewhere around 3 to 5 centimeters of water. And we're going to normally start our ventilator patients off on around 5 of PEEP. We're going to use higher PEEP in patients with a shunt or VQ mismatch. So these are going to be our pulmonary edema patients, CHF patients, ARDS patients, H1N1 patients, patients with lots of consolidation and lots of junk in their lungs so that we can allow the gas exchange to occur. We're going to use lower PEEP levels in our obstructive patients, so our COPD patients. Problem with COPD patients is that they can't get air out, but they can get air in. So what happens is because their inability to get air out effectively, they do what's called auto PEEP, And if we add more PEEP to that, we're only going to exacerbate the problem and cause their condition to worsen. So the best way that I can describe PEEP to you is if you imagine a balloon that we filled with water. We're going to have a water balloon fight. This balloon is tight. It's perfect. It's not, there's not really much air in there. It's just water. And imagine that as an alveoli filled with fluid from congestive heart failure. So when we add PEEP, what we're doing is we're adding air to that balloon. And now we've got the same amount of fluid in there, but we've got much more air. We've got greater surface area. Now gas can exchange through that, opposed to when it was just fluid, gas doesn't exchange well through that. So we add PEEP, increase the surface area, allow gas exchange to happen. So think of PEEP as oxygenation. So PEEP versus CPAP. A lot of people are often confused with this. The first kind of misnomer is that CPAP pushes fluid out of the lungs. You hear it all the time. Ma'am, we're going to put you on CPAP. We're going to just push that fluid magically out of your lungs and you're going to be all better. It's not how it works. PEEP and CPAP work to achieve the same goals, but they arrive at the destination in different ways. CPAP, or continuous positive airway pressure, provides that pressure both on the inspiratory and expiratory phases. So as the air comes in, it helps stent the alveoli open. As the person breathes out against that pressure, it stents the alveoli open. PEEP works to provide the pressure on the expiratory phase. So the air goes in, and as they breathe out, the pressure acts as a pneumatic stent, opening the alveoli open to allow gas exchange. Hope that makes sense. So how do we set up the ventilator for pre-hospital patients? So what we're going to do is we need to complete the RSI, complete the intubation. We're going to determine the patient's ideal body weight. We should already have that because we're doing an RSI generally. We've used it. We're doing it based on our drugs. So we have an ideal body weight. Then we're going to figure out the tidal volume. How do we do the tidal volume? Remember, we're going to take 8 mils, multiply that by the ideal body weight to give us our tidal volume. Then we're going to determine the respiratory rate based on the patient's needs. Remember, consider their CO2 levels and pH. I know we don't have a way to do a point of care pH. However, think about what's going on with them. If they're a sepsis patient, if they're a DKA patient, they're severely acidotic, what they got going on with them, we're probably going to need higher respiratory rates based on their needs. If they're a trauma patient, they're a normal, healthy person, just got in a car accident, we're RSIing them for a decreased level of consciousness, we could probably put them at a regular respiratory rate, maybe a little bit higher to overcome some of the hypercarbia that's occurred over the course of the RSI while they were apneic. Then we're going to go to the chart that's affixed to the top of our ventilator. We're going to set their respiratory rate and their minute volume. And we're going to do that by going to the respiratory rate that we've selected. We're going to go down the chart to the tidal volume. Once we find our appropriate tidal volume that we figured up above, we're going to drive to the left and we're going to find our minute volume. We're going to set those two knobs on our ventilator. I have the chart, or the revised chart, I should say, later in the slideshow that we'll use as an example. Once we find our minute volume and respiratory rate, we're going to set our FiO2, 60 or 100%. Based on their needs, we can start it at 100 and adjust lower, start at 60 and adjust. Just base it off of where your SpO2 and your end tidal are. Then we're going to set our PEEP. We're going to start at 5. We're going to go higher in CHF, pulmonary edema patients, patients with a large shunt or VQ mismatch. We're going to go lower in COPD patients or obstructive patients. Then we're going to set our Pmax. Pmax is going to be the pressure at which our pop-off valve or our pressure limit is activated. So in patients that are large, obese, we might need to set the Pmax higher so that the air as it comes through doesn't reach that pressure limit, not delivering the air all to them. So if they're a big obese patient, we're going to start at 40 and probably have to work our way higher, up to 60 possibly. But if you set it at 20, it's going to reach that pressure limit too soon, and they're probably going to tell you, if they're a long-term ventilator patient, that they're not getting enough air. But if they're RSI'd, you might be delivering lower volumes to the patient than you actually want to, and you're going to have that pop off. We're going to attach the vent circuit, attach our end-tidal CO2, and we're going to hit print. We're going to make sure that we attach a waveform capnography to our PCR every time that we move the patient, anytime that we hit a large bump in the ambulance, anytime that we're concerned of what our value might be and whether there could be a possibility of a tube dislodgement. Make sure you hit print. You can't hit it enough. Long-term ventilator patients. So we're going to go to a ventilator care adult home. We're going to go to a skilled nursing facility with ventilator patient. These patients are awake. They're breathing on their own. They're on generally a trach with a ventilator attached. So we're going to go in. We're going to obtain the current vent settings from the RT or staff. Sometimes they give it to you in a paper. You're going to take those. We're going to write them down and bring that paper with us so that we have them for future reference and charting. But we're going to next determine their minute volume. We can take a respiratory rate times tidal volume, figure it out, put it into our ventilator, or we can refer to the chart on our ventilator using their settings. Take the respiratory rate that they have set, take the tidal volume, find it on the chart, go to the left, find our minute volume. Then we're going to set our FiO2, set it as closely as possible to what they have them already on. We're going to set the PEEP based on what they have. Then we're going to set our Pmax at 40. And we may need to adjust it up for larger patients or patients who feel like they're not getting enough air. We're going to attach our circuit and our end-tidal CO2, and we're going to hit print. Print a lot. Can't say it enough. So what happens if we run into some problems? So make sure that we run through these steps. So usually the low pressure alarm and the patient saying they're not getting enough air kind of work hand in hand. We're going to check first to make sure that our oxygen sources are fully open and have adequate supply. Remember, this vent is a pneumatic vent. It requires pressure and an air supply to work effectively. If we don't have that, then we're going to hit low alarms. Our patients aren't going to be getting enough air. Then we're going to make sure that our vent circuit isn't kinked to the point where it caused a leak or otherwise damaged. We're going to check our Pmax level, make sure that it's up high enough. If the patient feels like they're not getting enough air and they're larger, crank it all the way up, make sure that it makes them more comfortable, and then back it off so that we're not over voluming these patients, and just make sure it's at a comfortable level for them, but make sure they're getting an adequate air supply. And then if that doesn't work, we've done all this stuff, we know that we've troubleshot and it's still not working, then what we're going to do is we're going to take the respiratory rate of the patient, not the one set on the ventilator, but we're going to take their actual rate and adjust our ventilator to match their own intrinsic rate. So usually these patients are set at respiratory rate of 16, tidal volume of 500, PEEP of 5. And so what we're going to do is we're going to set it to where they're breathing at, and making sure that every time that we change our respiratory rate, we refer to the chart and we adjust our minute volume based on that. You cannot change respiratory rate on our ventilators without changing the minute volume and keep the same tidal volume. You will cause problems, possibly barotrauma or under volume, or giving these patients too little volume if you do not adjust the minute volume. So what happens if I have a blood pressure drop? So too much PEEP can decrease cardiac output, which will give us a lower blood pressure. So what we're going to do is if they're on higher levels of PEEP, we're going to drop down the PEEP to allow the blood pressure to recover, but making sure that we're not sacrificing oxygenation for blood pressure. What we really want to do is take a look at their mean arterial pressure. If their mean arterial pressure is somewhere between 65 and 70, 75, we're in good range. Keep it around that. But if their blood pressure or their mean arterial pressure is in 60s, 55, then we need to adjust our PEEP down if there's no other reason for why their blood pressure is dropping, i.e. they're bleeding out, we've given them a bunch of benzos that have caused their blood pressure to drop, whatever the case may be. But if everything was fine, all of a sudden we put them on the ventilator and now they're dropping, take a look at your PEEP. So ventilation issues. What happens if their CO2 is getting out of whack? So remember, respiratory rate and CO2 kind of work inversely of each other as well. As the respiratory rate goes up, CO2 is going to go down. As the respiratory rate goes down, CO2 is going to go up. So if we're ventilating someone either with a BVM or a ventilator and we need to fix CO2, we're going to change respiratory rate. That's the knob that we're going to change. Just remember, in our ventilator, if you change the respiratory rate, you need to change the minute volume to keep the same tidal volume. What about oxygenation issues? Well, we have two things we can check. Check our FiO2. If we're at 60, move them to 100. If you're already at 100, then now we're looking at PEEP. So we're going to adjust the PEEP higher to increase our oxygenation. So the chart that I have here is from the ARDSNet group, by far the gold standard when it comes to ventilator management, and especially the relationship between FiO2 and PEEP. This is just one of the many charts that they have, and I'm using it as an example because I want to show you that patients generally can tolerate higher levels of PEEP than we think. So if you look at the chart and you see where they have the FiO2 at 100% or 1.0, you see that they have a respiratory rate of 18 to 24. A PEEP of 18 to 24. At 60%, they have a PEEP of 10. I'm suggesting we start patients out at 5 and adjust from that point. So it still surprises me when we bring patients in on CPAP at 15 or 25 liters of oxygen, when we're running them at PEEPs of 10, 11, 12, and no one bats an eye. However, when we come in with patients on ventilators, we have those levels of PEEP, everybody starts to kind of freak out, doctors, RTs, or whatever. It's the same difference, right? You got to make sure your blood pressure is good, and we got to make sure that they can handle the PEEP hemodynamically, but just know that you're not likely going to blow someone's lungs up by just giving them PEEP if you're paying attention and judicious with it. We don't want to put patients on large amounts of PEEP for no reason, but if they've got a large shunt, if they've got pulmonary edema, something going on that's causing that VQ mismatch, we need to adjust their PEEP up to keep them oxygenated. So here's the revised chart that I've created for you guys. And what it's designed to do is give you kind of a quick setup guide, step-by-step instructions on how to set up the ventilator. You just follow it, starting at step 1, figuring out your ideal body weight, moving to your tidal volume. We're going to set our respiratory rate, then our minute volume, and then we're going to do FiO2 PEEP, set our Pmax, and then attach our end tidal CO2 and print. So I told you I would give you kind of an example of how this chart works earlier in the slideshow. But let's take a respiratory rate of 18. Let's say I've been intubated. We're going to put me on a respiratory rate of 18, and we know that my tidal volume is going to be about 560 based on my ideal body weight. So we're going to go to a respiratory rate of 18, which is along the top portion of the chart. We're going to go down until we find the 560. And then we're going to go to the left till we get to the vertical column, which is our minute volume. And you can see that I need a minute volume of 10. We're going to put those into the ventilator. respiratory rate of 18, minute volume of 10, and then move from there. But let's say that throughout the course of the call, you decide that I need a lower respiratory rate. Let's say we're going to move me down to 12. We're going to go to 12 and we're going to go down. If we don't change the minute volume, I want you to see what you're doing to my tidal volume. So if you go down to the minute volume of 10 and come to the 12, you see that my tidal volume is now 830. You're now giving me 300 more mils, essentially, of volume that I may not need, and you could cause problems for me. So what you need to understand is that if you move me to 12, I'm now going to be at a minute volume of around 7, and you need to adjust your ventilator for that. Now let's say my tidal volume is 600, and you're going to put me on a respiratory rate of 18. So we go down, and now you don't see 600 on there, right? I'm somewhere in between 560 and 670 on that chart. I'm going to ask that you opt for the higher volume and minute volume. So I'm going to say go for the 670, put me on a minute volume of 12. That way it kind of helps overcome some of the dead space in the vent circuit and gets me at least the volume I need. You can always back it off if you need to, but consider if you're in between tidal volumes and minute volumes, opt for the higher one. So let's review a little bit about what we talked about. Respiratory rate. Remember, not all patients need a normal respiratory rate. If we're going to RSI someone out in the field, I suggest putting them on a respiratory rate of 18 to 20 to overcome some of the hypercarbia that's occurred over the course of the RSI. Chronic vent patients, if their vent settings at the facility aren't adequate for them, change the respiratory rate to match their intrinsic rate and change their minute volume. FiO2, either 60 or 100%, based on the needs that you feel like they need at the time. We're going to start at a PEEP of 5. We're going to adjust based on blood pressure and their need, higher for chronic COPD patients, VQ mismatch patients, H1N1 patients, ARDS patients, all those patients with junk. Lower for our COPD patients. We're going to use tidal volume using 8 mils per kilogram of ideal body weight. We can figure our minute volume by multiplying our respiratory rate times our tidal volume. Otherwise, use 100 to 120 mils per kilogram of ideal body weight. And just remember, I've said it before, I'll say it again, make sure you change minute volume if you change respiratory rate and you want to keep the same tidal volume. If we need to affect their ventilation status, change our respiratory rate. If we need to affect oxygenation, that's occurred through FiO2 and PEEP. So I hope that gives you a quick little overview of our ventilator and basic mechanical ventilation theories and stuff. There's lots that we could talk about in terms of different modes, different tidal volume strategies, but really what I want to do is get you comfortable with using this on transfers and in the field, because it really does work well if you work through the troubleshooting stuff, are using it as often as you can, and I really want to make sure that it's comfortable for you. You're always welcome to give me a call, text, email me, whatever, if you have any questions with regards to it. And as a little disclaimer, I want you to know that if I have said anything throughout this that doesn't make sense, please do not hesitate to contact me. My intention is never to be inaccurate. However, as many times as I do lectures and things like that, there's always a chance that I've mistakenly said something wrong. It's never my intention. So if you notice anything, please feel free to contact me and give me a call. Let me know that I've messed up, and I'll do my very best to fix it. Thank you very much, and I look forward to seeing you guys again. Thanks.